Morning, everyone, and welcome to the second grand rounds of the season. So nice to have everybody here. I want to acknowledge this morning the support of Janssen Pharmaceuticals, Chuck and Chelsea. So thanks to them for the support of our grand rounds. And I also want to mention that there are two or three important speakers coming up besides the one from this morning. And that would be Dr. Catharason. October 3rd is the Gram Prevention Lecture. He is a CEO of Verve Pharmaceuticals, I believe. It's a company which deals with gene editing to treat hyperlipidemia. And so he's going to bring that perspective to us. Then we have Dr. Philippe Pibereau from Quebec coming in. The Monday before Thanksgiving is going to speak to us about all the different flavors of aortic stenosis these days. That'll be a really good talk as well. And we just have Dr. Douglas Mann from Washington University has accepted our invitation to deliver the virtual lecture, and that will be in April. So look forward to that, but especially now this morning, look forward to having my friend and colleague, Dr. Rob Fraser. Everyone knows Rob's expertise in hypertrophic cardiomyopathy. He's taught us so much about it and has taken the lead, and this morning he's going to speak to us about myosin inhibitors. So take it away, Rob.
Thank you. All right, thanks for the introduction, Dr. Sharkey. Thanks to the foundation for hosting me this morning. Thanks to Janssen and Kaniska for sponsoring today's lecture. So today's presentation is titled Hypertrophic Cardiomyopathy, Myosin Inhibitors in Context. And this is a single disclosure I have today. This is a timely topic because the FDA just recently approved mavacamten, which is a novel myosin inhibitor for the treatment of obstructive HCM. So what I'd like to do today is talk about this new therapy in the context of the greater obstructive HCM space and explain why, when, and how we can use this drug to treat our patients. We'll do so with the following roadmap. We'll talk about the history and epidemiology of HCM. We'll talk about the burden of obstructive HCM. We'll then talk about current therapies and close with a discussion on the myosin inhibitor or myosin inhibitors. So first, for history, contemporary HCM was first described by Dr. Tier, who was a pathologist in London in the 1950s. He wrote about asymmetric LVH in 8 young individuals who died suddenly and unexpectedly, describing both the gross and histologic features. He was originally suspicious that this was tumor, but it has since been proven not to be the case. And the original article has gone on to be cited over 1,200 times. HCM is currently defined as a disease state characterized by unexplained LV hypertrophy associated with non-dilated ventricular chambers in the absence of another cardiac or systemic disease that itself would be capable of producing the magnitude of hypertrophy evident in a given patient. Or simply said, this is unexplained hypertrophy and typically defined as greater than 15 millimeters. Now, multiple different cohort studies have reported similar HCM prevalence, that is about 1 in 500. For instance, the Cardia cohort screened over 4,000 23 to 35-year-old individuals in the United States with echocardiograms, defining HCM as a wall thickness greater than 15 millimeters, absent hypertension and valve disease, and found a prevalence of about 1 in 500. If you notice the citations, I'm going to pause just to say that MHI and MHIF have a very rich history of HCM-related research and patient care. And many of the studies today will include, when appropriate, citations for our colleagues, both past and present. So if we look at recent US Census data and a 1 in 500 prevalence, we can say that there's probably over 600,000 patients in the United States who have some form of hypertrophic cardiomyopathy. However, when you look at a large US claims database encompassing over 100 million lives, and you search for HCM-related diagnostic codes, the prevalence comes out to be closer to 1 in 3,200. So if you marry these two data points, it may be that as many as 6 out of 7 patients with HCM have not yet been recognized or are unaware of their diagnosis. As for obstruction, before we go too far, because we have a broad audience, we're going to first just go over some anatomy and physiology here. So what I've labeled are the mitral valve, As blood passes from the left atrium into the left ventricle, goes through the mitral valve, and then it's ejected from the left ventricle through the LVOT, that is the left ventricular outflow tract, through the aortic valve and into the aorta. And this will be discussed time and time again throughout the talk. So this image is of one of the more common phenotypes of HCM, and that is prominent basal septal hypertrophy with systolic anterior motion of the anterior mitral leaflet. What I mean there is that when the LV contracts and blood is ejected into the aorta, we see that the mitral valve moves over and kisses or taps the basal septum, and that obstructs flow. It shouldn't happen. It increases the pressure in the left ventricle, can lead to mitral regurgitation and symptoms. Now, we previously talked about the definition of HCM, and obstruction is not a part of the definition. So this is a very common feature of the disease, but definitely not universal. Here's another example. This is echocardiographic. We see very prominent systolic anterior motion of the anterior mitral leaflet. When we add color, we see that there's turbulent flow in the LVOT, and we see that there's posteriorly directed mitral regurgitation. Now, SAM, or systolic anterior motion, is multifactorial and unique to each individual, with contributing factors including but not limited to LV hypertrophy, hypercontractility, various push-pull forces on the anterior mitral leaflet, as well as abnormalities in the mitral valve, like elongated leaflets, abnormal secondary chordae, and also potentially displaced papillary muscles. And all these things need to be taken into context, particularly if someone's being considered for surgery. Obstruction in HCM is typically defined as a peak gradient greater than 30 millimeters of mercury. And this gradient is dependent on loading conditions. It's dynamic. It can increase and decrease with provocation. So we can increase it by decreasing preload, decreasing afterload, or increasing contractility. And when we look at a large cohort of HCM patients from 3 referral centers, including our center here, we see that about a third of the patients have obstruction at rest. A third of the patients don't meet criteria for obstruction at rest, but do with provocation. And then a third do not meet criteria for obstruction. So based on this, we can say that about 70% of patients with HCM have the obstructive form. Here's an example of that is dynamic obstruction. These Doppler tracings were obtained from the same individual over the course of just 10 minutes. We see that at rest, the patient does not have obstruction. They don't mount a gradient of 30 millimeters of mercury. After Valsalva, the gradient jumps to 64, and after having them inhale amyl nitrate, which is a venovasodilator, the gradient increases further to 123 millimeters of mercury. And so now we'll show how obstruction fits into the greater HCM disease. If HCM is going to manifest clinically, it's typically as one of 3 not mutually exclusive pathways, and they are heart failure, atrial fibrillation, and sudden cardiac death events. I have to point out that on the left, the orange bar shows that almost 50% of patients who have an abnormally thickened ventricle have no symptoms, okay, or are asymptomatic. But of those that manifest something, 43% manifest heart failure, the majority of which is due to obstruction, rather as opposed to the non-obstructive phenotype. About 20% have atrial fibrillation, and 6% have some kind of clinically relevant ventricular arrhythmia event or sudden cardiac death event. We're going to focus mainly on the obstruction today and less so on the arrhythmias. And so when we look at heart failure in obstructive HCM, this is not the chronic fluid retention and diuretic cycle that plagues patients who have the typical systolic and diastolic heart failure. These patients are not admitted to the hospital for IV diuretics, but rather their symptoms are chronic shortness of breath or chronic chest pain due to high LV pressures from the LVOT obstruction, with or without mitral regurgitation. Some also experience chronic lightheadedness due to the same phenomenon. So again, we don't treat with diuretics like we do typical heart failure. We need to figure out a way to reduce the LVOT obstruction and decrease the pressure in the left ventricle. And so how does this play out? Well, here's some cohort data. This was published in the New England Journal of Medicine by Drs. Marin, Lesser, and Susan Casey, as well as others. On the left, we see that obstruction is associated with HCM-related death when compared to the non-obstructive form. And on the right, we see that escalating degrees of obstruction according to NYHA status are associated with increasing rates of HCM-related advanced heart failure symptoms, stroke, and death. So simply having some symptoms predisposes you to progression to more advanced symptoms, and it's based on this that some say that HCM can be a progressive disease. Here's complementary data displayed differently. This is a little bit busy, so we'll walk through it. And basically what it's showing is it's taking a large cohort of patients and it's stratifying these HCM patients into those that are non-obstructive, those who have provocable obstruction, and those who have rest obstruction in the various circles. And then the salmon color, or pink, shows the percentage of patients that over the 7 years of follow-up go on to develop class 3 or class heart failure. And we see that heart failure is much more common, or I should say advanced heart failure is much more common among those who have rest obstruction than those who have the non-obstructive form, with those who have provocable obstruction in the middle. Okay, so let's jump into contemporary therapies. Like any condition, the ideal therapy is going to improve symptoms, improve outcomes, be safe and well tolerated, and be accessible both logistically and economically. Now, most of our trial data for HCM is going to focus on symptom improvement. There's not a lot of data that supports any particular treatment has an impact on outcomes. And furthermore, I'd point out that there really is no evidence that we should treat patients with HCM who are asymptomatic. We're really just focusing on treating those who have symptoms. We'll start with beta blockers, calcium channel blockers, and disopyramide, which I'd call the traditional medical therapies. Now, despite there being over 20,000 publications related to hypertrophic cardiomyopathy on PubMed, there are very few that show evidence for pharmacologic therapy in these patients. To illustrate the point, one author pulled all HCM-related pharmacotherapy studies between the 1950s and 2012 and found that only a handful had more than 50 patients. And of those, highlighted by the little green star, only 3 were prospective. Dr. Masri out of OHSU put together this timeline recently, it was about a summer ago. He's outlining all the randomized controlled trials among patients with hypertrophic cardiomyopathy. Now, the obvious point is that there's very little data here, especially when we account for the fact that Pioneer and Redwood were both phase 2 trials of the myosin inhibitors, mavacamten and aficamten, respectively. We're going to talk about Explore, and we're going to talk about Tempo later in this talk. So the exploration into pharmacologic therapy for HCM began when doctors Cohn and Brunwald showed that propranolol reduced the LVOT gradient in a very small group of patients with the condition. The same was proven for verapamil. And then we jump forward in time. Disopyramide was the third drug studied, initially in the early 80s. Now, the largest cohort studying disopyramide in patients with HCM was non-randomized, followed patients for a number of years, and found that disopyramide reduces the LVOT gradient. Very few had to stop the medication for side effects, and none stopped the medication due to QT prolongation or arrhythmia. There was no difference in atrial fibrillation between the cohorts of those that were on or off the medication. Again, non-randomized data. The drug use is definitely regional, if not institutional. I think that for the most part, its use here and in many centers is used as a bridge to septal reduction therapy. This is because of the perceived side effects as well as the perceived QT prolongation. Some centers even require this to be initiated during inpatient observation, similar to something like dofetilide or Ticasin. And what I mean as bridge is you have someone who's having breakthrough symptoms on beta blocker and or calcium channel blocker. You think that they're a good candidate for some kind of septal reduction therapy like myectomy or septal ablation. And so you offer this as a medication to use kind of to bridge the gap, again, because of the perceived side effects, despite, I would argue, with evidence that contradicts that, generally well tolerated. We'll jump forward to what I would consider to be contemporary data. This was very recently published in JACC of last year. This is the Tempo trial. It evaluated metoprolol in 30 patients with obstructive HCM in a randomized parallel crossover design. Now, with 30 patients, this is the largest and most comprehensive study of beta blockers or calcium channel blockers in hypertrophic cardiomyopathy. In this study, the dose of metoprolol was increased to max tolerated up to 150 milligrams or the equivalent daily. And what was shown was that the beta blockers reduced the average LVOT gradient, but this was most impactful on the provocable gradient rather than the rest gradients. But it's important to note that many patients saw no change in their gradient. Before we go any further, I want to just outline a couple of tools that we're going to use time and time again throughout the rest of the talk. I've already hinted at this one, but just because we have a broad audience, I think it's really helpful to have a good understanding of it, because our outcomes are mainly focused on symptoms, less so on the traditional hard outcomes, as we say, events and mortality. So this is the NYHA classification of heart failure severity. This is a tool that classifies patients according to heart failure severity. And you can move from class to class as a patient, either as your symptoms advance as the disease progresses, or you can move down in class as you respond to treatment. Patients who are class 1 have the condition but have no limitations or basically no symptoms. Patients who are class 4 have symptoms at rest, with 2 and 3 in the middle. You can think of 2 as having very mild symptoms, or symptoms, I think, with heavy exertion. Class 3 patients have symptoms with minimal exertion. Think about moving around your house and being short of breath, or possibly having chest pain when you go up a flight of stairs. The other tool I want to highlight is the KCCQ. This is the Kansas City Cardiomyopathy Questionnaire. It's a self-administered tool that measures symptoms, physical and social limitations, and quality of life among patients with heart failure. It's scaled from 0 to 100, with 100 being the ideal score. And this has recently been validated in a large HCM cohort. We'll use this as well to track symptoms as patients do or don't respond to therapies. So if we return to that tempo data, this is the beta blocker trial, randomized parallel crossover design. I'll point out a couple things, and that is that metoprolol was associated with a modest improvement in functional status. Only 10% of patients while on metoprolol achieved NYHA class 1 status or were nearly absolved of symptoms. Okay, so most patients on metoprolol therapy continue to have symptoms. And the average KCCQ summary score was 3 points higher with metoprolol. Okay, this is again scaled from 0 to 100. 3 is not a very big change. We'll show how this compares to some of the other therapies later on in the talk. I'd say in summary that metoprolol can improve gradients, but marginally improve symptoms in patients with obstructive HCM. I'd also highlight here on the KCCQ results that some patients had a paradoxical effect and actually felt worse on beta blockers, and I think many clinicians experienced this reported in clinic as well. So here's the current AHA-ACC 2020 HCM guideline algorithm for the treatment of symptomatic LVOT obstruction in patients with HCM. Shout out to Dr. Saraja, who's one of the document's authors. The aforementioned beta blocker trial, as well as the soon-to-be-discussed myosin inhibitor trials, were not yet published when this document was put together, so they're not incorporated. To briefly say how this works, if a patient has symptoms, the first thing we want to do is avoid vasodilators and diuretics, which can worsen symptoms by increasing gradient. We then consider beta blockers or calcium channel blockers. If there's persistent symptoms, so I think there often are, we consider disopyramide or septal reduction therapy. Now, I just bring up the point that I think most clinicians would agree it's convenient to put together algorithms and figures for the sake of simplicity, but a lot of this tends to fall apart when you're looking at one specific patient in front of you. In many cases, we're incorporating medication side effects as we choose to prioritize or deprioritize any particular medication therapy. So I've outlined some of the common side effects or adverse effects or considerations when we prescribe these commonly used medications. Now if we move on to traditional invasive therapies, that is myectomy and the alcohol septal ablation. So here's pictures of the myectomy procedure. Dr. Bobby Steffen, one of our cardiac surgeons, gave a very nice grand rounds on the surgical treatment of HCM about 3 years ago. The traditional extended myectomy is performed via transaortic access, so the surgeon cuts into the aorta, can then peer through the aortic valve and excise the septum, and then close the aorta on the way out. There's a robotic version offered at some centers where the surgeon enters the left atrium with the robot. He then cuts through the base of the anterior mitral leaflet to create a window into the LV cavity, can then excise the septum through that window, and then on the way out, he or she would plicate the anterior mitral leaflet or close the anterior mitral leaflet which would further reduce the propensity for systolic anterior motion of that valve. Now, there's some really interesting history here. This is a picture of Dr. Andrew Glenn Morrow. He was the first to perform and describe this surgery while he was the chief of surgery at the NIH in the 1960s. The first version of the surgery was called the Morrow procedure. What's fascinating is that he was actually diagnosed with obstructive HCM by Eugene Brunwald by auscultation in 1961, while the two were collaborating to first describe the condition. He unfortunately went on to develop progressive heart failure symptoms. He developed atrial fibrillation and had an embolic stroke. It's been published that his kids had the disease as well. So first and foremost, with any therapy, and with myectomy in particular, we have to talk about safety. So we can see that at very high volume centers, this is a very safe procedure. The 30-day operative mortality rate, again, at high volume centers is less than 1%. When you compare 1% or less than 1% mortality at a high volume HCM center up against mortality rates for all cardiac procedures in the STS database, you see that this is, again, a relatively safe procedure. We're highlighting things like mitral valve repair, isolated CABG, and then more complex cardiac surgeries as we move across the screen. Again, these are not at the same center highlighted here. These are just pooled numbers from the STS database. The point is that we cannot extrapolate outcomes at a high volume center across the board. This study tried to stratify myectomy centers according to tertile based on volume. We see that low volume centers had much better outcomes. See that high volume centers had much better outcomes than low volume centers. I've chosen to highlight the in-hospital mortality rates here. You see that even in the highest volume tertile, which is which dilutes the highest volume centers, okay, because I previously mentioned mortality rates under 1%. The highest volume tertile has mortality rates that approach 4%. The lowest volume tertile can have in-hospital mortality rates that approach 15%. So how about the symptom outcomes? Again, published from a high volume center. This is Tufts data, and it's very important to look at the baseline symptom burden, okay, because we're going to use this to compare the various treatments as we move throughout the talk. We see that 98% of patients who underwent myectomy had class 3 or 4 heart failure, okay, so very symptomatic. After surgery, almost 2/3 were class 1 status or were nearly absolved of symptoms. 1/3 had class 2 symptoms, and about 1 in 20 or around 5% continued to have significant symptoms remaining class 3 or 4. Now this is drastically different compared to that beta blocker data I showed you previously from the Tempo trial. We'll compare it all later side by side. As for KCCQ data, this is from another center, so not the same center, but another high volume center. This is Cleveland data. We see that the mean change in KCCQ score in this prospective study was plus 38 points. Again, drastic when compared to the plus 3 points with beta blocker therapy. There's not a lot of long-term outcomes data for myectomy. Here is one cohort that was followed for more than 10 years. 140 patients. We see that survival was excellent. Only 7% had passed at 10 years. Most of the deaths were not related to hypertrophic cardiomyopathy. Of those that survived, most of them remained in class 1 or 2 heart failure. Okay, so not only is this a safe procedure and an effective procedure, but this can be a durable procedure when performed at a high volume center. I mentioned earlier that most evidence targets symptom-related endpoints. There's no randomized studies that have compared myectomy to no myectomy. There's some cohort and retrospective data that shows that if you qualify for myectomy and undergo myectomy, you do better than if you don't undergo myectomy, but that's obviously going to be littered with confounding variables. But this is one interesting study out of Cleveland that I wanted to point out. They took a look at myectomy timing and heart outcomes with a composite of mortality and ICD shock. The authors defined early myectomy as those patients who had class 2 symptoms and traditional myectomy as those who had class 3 symptoms. Again, this is not randomized, this is just hypothesis generating. But those that are blue, who underwent early myectomy, had lower rates of the composite outcome than those who underwent traditional myectomy when they had class 3 symptoms. The black line here is an age and gender matched non-HCM cohort. So the survival of those who underwent early myectomy match those, or match that of a cohort who was healthy without HCM. I would say that in summary, not necessarily related to this study, which I think again is hypothesis generating, that early myectomy may improve outcomes. Myectomy at a high volume center can be safe, it can be effective, and it can be very durable. We'll now jump to septal ablation. You can think of this as a percutaneous option for myectomy. Alcohol is instilled via angiography into a septal perforator to cause a controlled infarct, which results in thinning and scarring of the basal septum. So you both mechanically reduce or increase the size of the LVOT. The decrease in contractility also decreases the propensity for SAM. First and foremost, again, talk about safety. This can, at a high volume center, be a safe procedure. This is some of Dr. Siraj's data from his time at Mayo. We see that 30-day mortality rates are approaching 1%, but you do have to point out the difference between this and myectomy, and that is that the pacemaker dependency rates are as high, not consistently, but as high as 20% following this procedure, compared to 2% in myectomy. There's no prospective randomized trial evaluating alcohol septal ablation versus myectomy, and these patient populations are naturally different. A large study at Mayo showed in 2019 there was no difference in long-term outcomes as far as survival was concerned among these two procedures. However, from this same data, it was shown that myectomy is superior for LVOT gradient reduction, both in the short term and the long term, as well as freedom from reintervention. And then don't forget the fact that alcohol septal ablation is much more likely to lead to pacemaker dependency. But then this year, patients from 2 additional centers in Boston and China were added to that same Mayo cohort. And based on these added patients, the authors concluded that despite multivariate analysis and propensity score matched analysis, that alcohol septal ablation is probably associated with increased mortality independently when compared to myectomy. I'd say there's a lot of conflicting data and the jury's still out. It's very hard to perfectly adjust for the 2 different patient populations, and we're going to be dependent on operator specific outcomes. And so why might this be? Well, Dr. Siraj had previously shown that any residual gradient after alcohol septal ablation is associated with increased mortality. And previously shown, Susan Casey and Drs. Marin and Lesser showed that patients who have obstruction tend to fare worse than those who don't. And so this may be why alcohol septal ablation patients don't do as well as myectomy patients, all things equal, because there's a higher chance that there's residual obstruction. As for alcohol septal ablation, here are the outcomes. Again, pointing out that 100% of patients had either class 3 or 4 heart failure symptoms at baseline. 57% went on to be class 1 status. 34% went on to be class 2 status. When you compare that to the myectomy numbers, we see that they're more or less in the same ballpark. Okay, again, we're only focused on symptoms as outcomes. We don't have any data to suggest that any intervention in hypertrophic cardiomyopathy improves mortality, really, or any other heart outcome for that matter, aside from defibrillators for primary and secondary prevention. So if we compare these 2 therapies side by side, what we could say is that both are dependent on operator-specific outcomes. Both offer low mortality. Myectomy is going to have higher efficacy and is not dependent on anatomy, whereas alcohol septal ablation is less invasive and comes with a shorter recovery, but is going to come with a higher rate of reintervention, higher pacemaker rates, and is going to be anatomy dependent. Just a brief mention of alternative therapies or alternative invasive therapies. I'm going to post 3 up here. Just know that there's multiple techniques that have been or are currently being explored as treatments for obstructive HCM. The MitraClip is unique because it does not target septal reduction. If you clip the anterior and posterior leaflets together, you decrease the propensity for SAM, or systolic anterior motion of that anterior mitral leaflet. Dr. Siraja and a team from our center published a 6-patient series describing the symptom benefit using MitraClip in patients with obstructive HCM who were not candidates for alcohol septal ablation, typically due to anatomy, and were not candidates for myectomy due to comorbidities. The second is the Percutaneous intramyocardial septal RFA. This is exactly as the name and image show. An ablation catheter is inserted directly through the chest wall into the basal septum to perform an ablation. Most of the research into this strategy comes from China. There was recently a 200-patient series published in JAMA Cardiology that did describe encouraging benefits, although I'm not sure that this is used outside of that country. Another strategy that's being developed and research, I'm not sure this has been explored outside of a pig model, is the transcatheter myotomy with septal scoring. So the septum has gotten a lot of attention with the advent of TMVR because the neo-LVOT, or when you put in a percutaneous mitral prosthesis, you can cause LVOT obstruction. And so interventionalists are trying to figure out ways to thin the septum to increase the size of the neo-LVOT. I'm not going to go into it in any more detail than that. But in this case, a stiff CTO wire is driven straight down through the septum and then tethered to a receiving catheter. Electrical energy is applied to the wire and you splay open the septum, which decreases LVOT obstruction. There's a couple other therapies. There's descriptions of an endomyocardial ablation, so think about an EP-like ablation of the basal septum. Others are trying to ablate the septum via cardiac veins, accessing via the coronary sinus. All these are experimental. I think the takeaway is that MitraClip is used off-label on a case-by-case basis. In China, they're exploring the percutaneous intramyocardial septal ablation. And there will probably be more exploration into this space in the future, especially with the advent of TMVR. Okay, so all of that was to kind of frame treatment for HCM up until April of 2022, with the FDA approving what is a novel therapy, a myosin inhibitor. This is branded Camzyos, and this is now on the market. And so to understand how this medication works, we're going to take it back a little bit. Recall that you have muscle, which is made up of muscle bundles, which is made up of muscle fascicles, which is made up of muscle fibers, which are the actual muscle cells, made up of myofibrils, which are then made up of sarcomere. This is the smallest defined unit of the muscle. And so the sarcomere is composed of multiple proteins. So hang in there with me here because this gets a little dense, but I think it's sort of helpful to understand how this new drug works. So myosin and actin are two of the proteins within the sarcomere that engage one another to drive muscle contraction, or what is known as the power stroke on the sarcomeric level. Myosin substructures called heads are activated when chemical energy is converted to potential energy via an ATPase. They then bind and utilize the potential energy to slide against one another or to drive that power stroke or muscle contraction. Now, the number of activated myosin heads is going to be independently or directly causative to the degree of contractility. The more activated heads you have, the stronger your contraction. HCM hypercontractility is in part due to an increased number of active myosin heads, supercharging the power stroke phenomenon. So mavacamten, which is a myosin inhibitor, limits the number of myosin heads that are activated at any one time, therefore reducing contractility. The way this works is by actually blocking that ATPase, which allows us to convert chemical to potential energy. Recall that hypercontractility contributes to LVOT obstruction, both independently by narrowing the LVOT, as well as through the hemodynamic effects that contribute to systolic anterior motion of the mitral valve. Now, mavacamten is unique because it's a pure negative inotrope. It reduces contractility without other effect. So that makes it dissimilar when you compare it to beta blockers, calcium channel blockers, or disopyramide, all of which impact the cardiac rhythm in some way, causing bradycardia or impacting the action potential. As a quick sidebar, a little bit unrelated, but I think worth noting, GALACTIC-HF was a phase 3 trial studying a myosin promoter, that is the opposite of mavacamten, among patients with systolic heart failure. This was published in the New England Journal in 2021 and showed that the drug was associated with a small decrease in heart failure hospitalizations but had no impact on mortality. It's been submitted to the FDA and we can expect comments sometime in November of this year. Now, if we look at mavacamten, there are 2 phase 3 trials that have evaluated this drug against placebo, both very recent. The first on the left is EXPLORE, which was published in August of 2020, which included mostly patients who had class 2 heart failure at baseline. The second, which is Valor on the right, was published in JACC just this summer. It enrolled mostly patients who had class 3 heart failure. Now, FDA approval of the drug was mainly based on data from Explore, the first trial, but I'm going to integrate both into today's discussion. In both cases, patients were started on low-dose mavacamten, and the dose was modified every 4 to 12 weeks according to ejection fraction and echocardiographic obtained LVOT gradient. We'll have to talk about that more later. First and foremost, again, has to be safety. And obviously, the primary risk with a negative inotrope like mavacamten is going to be systolic dysfunction. So in the two studies, the incidence of a decline in EF below 50%, which is very abnormal for the hyperdynamic hypertrophic LV, ranged from 3 to 12%. All affected patients saw recovery of LV systolic function after drug hiatus, and there wasn't really any other major adverse event reported in either trial. Here's some data from Explore, and I'm choosing Explore because it followed patients for a longer period of time than Valor, but just know that the trends are very similar between the two studies. We see that the ejection fraction decreased about 4% over the first 12 weeks and then remained rather stable thereafter. Again, this is average ejection fraction. The resting LVOT gradient, the NT-proBNP, and the high sensitivity troponin all followed a similar pattern. Now, how about the symptoms? Because that's what we're really focused on. The patients don't come into clinic and report what their LVOT gradient is. They tell us how they're doing symptomatically. This is Explore data. I mentioned that most of the patients, were class 2 at baseline. About a third or less than a third had class 3 symptoms. So this is a different cohort than those who undergo myectomy. That being said, 50% of patients achieve class 1 status versus 21% on placebo. When you compare these numbers to the myectomy numbers, you see that the obvious takeaway is that the patients were less sick. Patients that underwent myectomy were far more symptomatic, and that the results were less robust. If you look at the Valor data, which I think is probably much more helpful, 93% of patients were class 3 at enrollment. So this group is much more similar to those who underwent myectomy and alcohol septal ablation. That's because active referral for either myectomy or for septal ablation was required in order to enroll in this study. So patients that were sent off to high-volume centers for some kind of invasive intervention were offered to be randomized to either placebo or to mavacamten. And what we found in this case was that 27% of patients on mavacamten achieved class 1 status or were absolved of nearly all symptoms. Again, if you compare this to the myectomy data, you can see that the patients are similarly symptomatic, but the treatment effect is slightly less, if not significantly less, prominent. Now a brief discussion about the logistics of mavacamten before we synthesize all this content. I mentioned earlier that the Explore and Valor trials dosed mavacamten based on echocardiographic LVOT gradients. All patients were under close surveillance, and echocardiograms were performed every 4 to 8 weeks throughout the study period. And LV systolic dysfunction was infrequent and reversible, but this is obviously a notable concern. Because of this, the FDA is mandating participation in what's called the Mavacamten Risk Evaluation and Mitigation Strategy Program. A lot of words, often abbreviated REMS. This requires enrollment from all stakeholders. And so there's currently about 60 REMS programs for various pharmacotherapies across the country. Most similar to our space, some of the advanced pH therapies like ambrisentan require participation in a REMS program. We'll talk exactly about what that means in a minute. Other psychotropic drugs, biologic therapies, chemotherapies, it's not uncommon for them to have REMS programs. And each REMS program is going to have its own varying degrees of complexity. For the mavacamten REMS program, branded the Camzyos REMS, it requires enrollment from the prescriber, the patient, and the dispensing pharmacy, of which there's only 5 specialty pharmacies in the country that are currently shipping this medication. The logistics of the REMS program for mavacamten are that patients must undergo echocardiographic monitoring and dose titration similar to that of the phase 3 randomized trials. Patients must have echocardiograms monthly for 3 months and then quarterly thereafter to document EF and LVOT gradient, which will be used to titrate the drug. Patients must also undergo medication reconciliation at these intervals and really throughout all mavacamten use to screen for drugs that interact with mavacamten, because concomitant use of certain drugs that induce or inhibit various CYP enzymes can increase exposure to mavacamten in unpredictable ways. All the above data, so the ejection fraction, the LVOT gradient, the medication reconciliation, must either be submitted or attested to online in the REMS portal on a monthly basis for patients to receive their fill. The drug's currently only prescribed in 35-day increments. You can't prescribe 60 or 90-day fills at this time. Here's an example of the initiation algorithm for the drug. We're not going to go into this in depth. I don't think there's any purpose. But you see how this works more or less in that all patients start on 5 milligrams, assuming their EF is greater than 55%. They get an echo at week 4, where you may maintain 5 or decrease at 2.5. You get an echo at week 8, where you adjust accordingly, again, based on EF and LVOT gradient. If things are going well, at week 12, you enter a maintenance phase where you space out echoes every quarter. So we've covered 4 different therapies. We've covered beta blockers, we've covered myectomy, we've covered septal ablation, and now we have mavacamten, which is a myosin inhibitor. And so you're looking at a patient in clinic who has obstructive HCM, and you're trying to decide what's best for this individual. Well, importantly, if they have no symptoms, there's no pressure to do anything, because there's no evidence that treating patients who don't have symptoms improves outcomes. Here's a side-by-side comparison of the various endpoints from the various therapies. The aim is to give relative context. This is obviously not a perfect comparison, but I think it's reasonable and the best we have available, the best I can certainly come up with. The data points come from multiple cohorts, but know that they are for the most part similar. 95% or greater of the patients had baseline class 3 obstructive HCM symptoms in all but the tempo trial, the beta blocker trial. I'd summarize this as follows. I think the efficacy improves as you move from left to right across the screen. To highlight mavacamten in particular, because it's the novel therapy or new kid on the block, it's certainly better than beta blockers, but probably not as good as a invasive septal reduction strategy. And I just point out that beta blockers, although they're able to reduce gradient, don't have much of a meaningful effect on symptoms in these patients. I think there's a lot of paradoxical effect in giving patients beta blockers. The various treatments can also be compared this way. If we look at safety in particular, we can say that metoprolol is excellent. The short-term safety data for mavacamten with echocardiographic monitoring is very good. Septal ablation, I think it's safe, but the pacemaker dependency rates are rather high at 20%. The myectomy data is very good, again, at high volume centers only. As for access to metoprolol is easy. Access to mavacamten is certainly evolving. It's a brand new therapy and comes with a REMS program, so it's probably less than straightforward. Access to septal ablation I consider to be fair, and myectomy is poor, because there's really probably only 5 or 6 centers in the country that can be considered of the highest volume that can reproduce those less than 1% operative mortality rates. We've, for the most part, already covered the hemodynamic effect as well as the symptom effect in these patients, and again, things improve as you move from left to right across the screen. Ultimately, I'd say that the decision as far as which pathway to pursue for any given patient should be made as a shared decision between the patient and provider. Many different variables should be taken into consideration, as one therapy may be good for one patient and not for another. For instance, let's say you have a patient with symptomatic HCM who also has multivessel disease. Well, that patient should get myectomy at the time of their CABG. If you have a patient who does not have anatomy that's conducive to alcohol septal ablation, you're going to need to choose between medication and myectomy. If you have someone who's too frail for myectomy, you're going to have to choose between mavacamten or septal ablation. I saw a gentleman in clinic just like a week and a half ago who had symptomatic obstructionist type beta blocker therapy, who was a Jehovah's Witness. He's not particularly interested in cardiac surgery, so he's going to choose between mavacamten and septal ablation. Again, this should be a shared decision between provider and patient, or provider, patient, and family, or any other stakeholders. Just 2 more slides, and then we'll wrap it up. So this is just a hit on what's on the horizon in this space. The Discover Registry is an industry-sponsored registry that we're going to participate in here, which will follow patients with obstructive HCM. Even if you're not sending your patients to the HCM clinic, please consider just pinging me through Epic if you're seeing an HCM patient who has obstruction, because we can track them as a part of the registry. They don't have to be on any particular therapy. The MAVA LTE registry, or the MAVA-Campton Long-Term Extension Registry. This follows patients who are continued on therapy in either the phase 2 or phase 3 MAVA-Campton trials. Some of the long-term data was published at ACC this spring. Results were very similar to the current publications. This was safe in a monitored setting. Sequoia is a phase 3 randomized trial evaluating aficamten for the treatment of HCM. This is another myosin inhibitor. Differences between this and mavacamten are that it's believed to have a wider therapeutic window and possibly a shorter half-life. So this is something we'll be monitoring. We're not participating in this study here. And then Amarone, which is the first of its kind. This is a randomized trial comparing alcohol septal ablation to myectomy with an aim of enrolling 100 patients in the Netherlands. Just getting started, so we're certainly many years out from hearing more about this. But just things for us or myself to have on our radar. So I'd give you these take-home points. I'd say that HCM is not uncommon and can be a progressive disease. I'd say that LVOT obstruction is the primary cause of HCM heart failure symptoms and predicts poor outcomes. There are multiple treatment strategies for symptomatic LVOT obstruction, and the best option is patient-dependent and best chosen via a shared decision. Mavacamten is a novel myosin inhibitor that is an effective treatment for obstructive HCM, but requires FDA-mandated monitoring via a REMS program. I want to just give a special thanks to my local mentors in this space. They include Drs. Lesser, Harris, and Saraja. At the foundation, I would thank Maya and John for helping to make today smooth. From a research perspective at the foundation, I thank Dr. Scott Sharkey. I thank Pam Morley. I thank Irina Davies, Karina Benson, Susan Casey. And then special thanks to some of the Abbott Pharmacy folks who have done a lot of work to help connect patients with mavacamten through the REMS program. Sam Wills, Allison Kaznowski, Chris Lombardo, the support of Tim Gallagher. I'd also thank the Eden Prairie Clinic team, the nurses, Rogan, our sonographer, and Rico, our manager, for helping to modify templates so that we can get these patients in for their monthly echocardiograms and visits as needed in order to participate in the REMS program. With that being said, that's all I have, and I'm happy to take any questions if you have any. Yeah, please.
Thank you very much. That was a spectacular talk. Can you give us a perspective on HCM and the Alina system? You know, number of patients, how many in class 1, 2, 3, how many do we see?
Not in depth. A little over a year ago, we pulled data just for our practice, which I don't believe included the United cohort. And I think there were something like 600 unique individuals that we were seeing. About a third of those 600 were being seen by an HCM provider. So myself, Drs. Lesser, Harris, or Saraja, and 2/3 of them were being seen by the rest of the practice. I can't speak to the current symptom burden. I think that's something we would certainly get with ongoing participation in that Discover registry, because it's not actively being tracked. Yeah.
Excellent talk, Rob. Really comprehensive, phenomenal. Is there any evidence that the novel myosin inhibitors cause regression of hypertrophy over time?
Yeah. So this was not a plant, but I actually threw this in there. I didn't get into it in detail. Just know that, so there was a sub-study within Explorer, only 35 patients, placebo and drug, that looked at MRIs in these patients. It's only going out 30 weeks, so it's not, you can hardly say this is long-term data. But there was some, I would say, positive remodeling. The outcomes they tracked were LV mass index, LV wall thickness, left atrial volume index. They all claim there was significant difference. Now this is very, very small difference, but statistically significant. There was no impact on LGE. And then as you would expect, there was an impact on EF. So yes, but very early. And I think yet to be seen is what happens long term. Because we really, Valor followed patients for something like 30 weeks. Explorer followed patients for something like 30 weeks. And then the long-term extension data that's been shared publicly only goes out 48 weeks. So we don't even have a full year's worth of data on drug. But yes, some early data. Yeah.
Thank you, Dr. Fraser, for that excellent talk. We do have a comment and a question in the Q&A pod online. Folks online, feel free to submit your questions and comments via the Q&A pod. The comment is fantastic summary. Thank you for taking the lead on this. And the question comes from Dr. Lesser, who asks, do you have any ideas about reorganizing HCM clinic to account for new therapies, amyloidosis included?
Yeah, that's a good question. I think there's certainly some synergy in the treatment of patients with hypertrophic cardiomyopathy and any other condition that causes a thick heart syndrome. These patients are typically identified by imaging, which leads to advanced imaging, and there's opportunity to pool them, both for the sake of diagnostics as well as treatment. And I say this especially as new or novel amyloidosis therapies come online. I think there's early talks, but nothing definite. But what I've realized in starting to prescribe mavacamten is that you do need some element of infrastructure in place, which I think you also need for these newer amyloidosis treatments for the sake of REMS and other various monitoring perspectives. So I think it's something we aspire to, but is not yet established. Right now, the focus has just simply been on jumping through the hoops for the Camzyos REMS and trying to help these patients access the medication and then develop what is yet to be defined an infrastructure on the back end, a team of nurses and or pharmacists and or other players that will interact in a seamless way because right now we are not yet seamless in helping patients get the various therapies. And again, I think the infrastructure that we have for HCM could be duplicated or could be multi-purpose and also used for patients who have amyloidosis, which would require collaboration with the heart failure team, who are currently the providers that are catching these patients in clinic and prescribing tafamidis, which is the one current FDA-approved medication for cardiac amyloidosis.
Thank you very much for that. There's one more question in the Q&A pod that comes from Dr. Moore. And she asks, can you comment on sudden death risks as it interacts with treatment modality?
Yes. So we don't have any data for mavacamten. There is some data, I believe that there is again, this is non-randomized, this is cohort, so it's plagued with confounders, but the risk of sudden death is going to be lower in those that qualify for surgery and undergo surgery than those who qualify for surgery and don't undergo surgery. There was the study I showed from Cleveland with the composite endpoint of death or clinically relevant ventricular arrhythmia, defined as ICD shock, that showed if you underwent early surgery, there was a lower rate of the composite. There's a lot of back and forth as to whether or not alcohol septal ablation increases your risk of sudden cardiac death because of the infarct and the scar in the septum. But the latest and all the data in some seems to be that there is no increase in risk of sudden death or clinically relevant ventricular arrhythmia in those that undergo alcohol septal ablation. There is likewise no data to suggest that alcohol septal ablation decreases your risk of sudden cardiac death in a meaningful way.
Thank you.
Could I ask a follow-up to that? Is how do we at this practice assess patients with HCM for primary prevention device?
Yeah, I think right now it's very provider dependent. So, it's hard to say more than that. So any individual provider who is seeing the patient is counseling the patient regarding the risks and benefits of an ICD and interpreting the data available, on their own with or without the help of the arrhythmia clinic. I think some providers use the arrhythmia clinic more than others to help make the decision, right? I think I'm pretty comfortable saying this person should or shouldn't get a defibrillator. I'm going to have you go see our arrhythmia doctors who will connect you with said defibrillator, whereas others may say, it looks like your risk is high or intermediate. I think you should go see electrophysiology for consultation regarding your risk and then make a decision thereafter. So it's not streamlined. It's very provider and clinic dependent.
Any others on Joe? That's it. Thank you very much.
Thank you guys very much for coming.